So I presented a subgroup analysis of the ICARIA study looking at the impact of the addition of Isatuximab to pomalidomide dexamethasone in patients with high-risk cytogenetic abnormalities, in particular 17p, 414 and 1416 abnormalities. And the bottom line of the study is that the benefit in the high-risk patients was at least as good as the standard risk patients in terms of overall response and also progression-free survival. Interestingly, in the patients with high-risk cytogenetic abnormalities, the response rate went up from around 20% to around 50%, and most of the difference is made up of improved depth of response in terms of VGPR rate, which went from around 3% to around 30%. So, as I said earlier, the benefit is at least as significant in the high-risk patients as the standard risk patients. The toxicity profile was similar, so when you add a third agent into a combination, you're usually associated with increased toxicities, but the infusion reactions are much less than some of the other CD38 antibodies. There was a slight increase in rate of infections and grade 3 events overall, but this didn't lead to any increase in the number of patients stopping drug. So overall, it's fairly similar in the two different populations. So I think that the main message is that, as I said earlier, the patients who with high-risk cytogenetic abnormalities benefit at least as much as the standard risk patients, and therefore in that area of need population, people with high-risk cytogenetic abnormalities, they should be offered an agent like Isatuximab if it's available to try and improve in terms of achieving a response, but also progression-free survival.